Good day. We'll get started here in a minute. Just let people file into the room. It's great to see. We have over 100 people already joining. Okay, hi, I'm Judith Currier from the University of California in Los Angeles, and I'm watching the popcorn pop as the number of people come into the room, and it looks like we're reaching a steady state. So thank you so much for joining us today for the State of the Art in HIV Management from CROI of 2023. I'll be moderating the session today, and I just want to go over a few introductory comments before introducing today's speaker. This program is developed by the IAS-USA, and the content on the web board are considered the CME planners, so their disclosures are listed on the slide. Also, the disclosures of myself and Dr. Daar are listed here as well. The IAS-USA is accredited by the Council for Continuing Medical Education, so you can get CME credit for the attending today's webinar. And the amount of credit that it's approved for is shown on the slide for different types of providers. The instructions for claiming this CME credit are on the IAS-USA website as well. This program is supported through grants from several companies, and they are all listed here on the slide, and they've had no input into the content of this program today. So after we complete the recording, it'll be available online for further viewing or for sharing with others. So this will be in 24 hours at the IAS-USA website. And I do encourage you to go onto the website. There's a lot of really great content, including the question of the day. So during today's webinar, we will be allowing people to post questions. Those need to be placed in the Q&A. The chat is open, but it is not to be used for the questions. And if you make a mistake, we'll get your question moved over. But we will take questions at the end. And so you can put them in at any time during the program, and we'll get to them and have time for some questions at the end. So without further ado, I'd like to introduce our speaker today, Dr. Eric Daar. He's the chief of the Division of HIV Medicine at Harbor-UCLA Medical Center and a professor of medicine at the David Geffen School of Medicine at UCLA. And I am privileged to have him as a colleague over many years. We were just joking that our pictures for this webinar, we look like we're both in high school. But Eric has really been a leader in clinical research in HIV, participated in guidelines, and led really important clinical trials that have helped to define therapy today. So there's really no one better to give us his view of what was new at CROI and where we are in the art of HIV and HIV management. So Eric, I'm going to turn it over to you.
Great, thanks, Judy. And thanks everybody at IAS-USA for the opportunity to make this presentation, and to all of you for joining. It's always a wonderful opportunity and a bit of a challenge to provide an update on a select topic from CROI. As everybody is aware, this really is the preeminent international meeting of the year in HIV/AIDS research, and there are on the order of about 1,000 presentations, many of which are related to treatment, but also other really important topics in pathogenesis, prevention, and beyond. My charge was really to try to pick out what I thought were some of the key presentations related to antiretroviral therapy in particular, and to share those with you. The learning objectives are listed here. Looking at the goal, learners will be able to list the most recent findings from clinical studies and antiretroviral management of HIV and its implications for these data for state-of-the-art treatment strategies, and to integrate the most recent data from the 30th CROI into your clinical practice. the disclosures have already been shared. And we have a couple of pre-test questions, and we'll be coming back to this with some post-test questions later in the talk. But this is just to get a sense as to your baseline knowledge from some of the key studies presented. So the first one is you have a female patient who's gained 20 pounds over 2 years while taking dolutegravir plus emtricitabine tenofovir lefenamide. Which of the following can you tell her, based on the characterized study, may happen to her weight if she switches to dolutegravir plus emtricitabine with tenofovir disoproxil fumarate instead of TAF? Gain weight, lose weight, no change? There's really no data to inform this question, or you're unsure. Go ahead and vote. Terrific. We'll come back to this later. The next question, as a patient who experienced virologic failure about 2 years ago on tenofovir disoproxil fumarate, emtricitabine, and efavirenz, and was noted at the time to have the mutations of K65R, M184V, and K103N, and then was lost to follow-up, and now presents very anxious to restart antiretrovirals with the CD4 count of 45 and an HIV RNA of 245,000 copies per mil. Her other labs are essentially within normal limits. And the question is, which of the following would you feel is the best option for this patient? A, darunavir cobicistat plus TDF-FTC. B, darunavir cobicistat zidovudine 3-TC. C, dolutegravir plus TAF-FTC. D, dolutegravir plus zidovudine 3-TC, or E, none of the above. Go ahead and vote. Perfect. It's always nice to see a good distribution at the beginning. So let's go ahead and start with what were some of the key studies. This was a study reported from the Swiss cohort that was trying to address the question as to whether integrase strand transfer inhibitors might be associated with an increased risk of cardiovascular disease. And by way of background, I think probably all of you are aware that this has been an important complication or event that occurs with increased frequency in people with HIV. And there's been a long asked question as to how certain antiretrovirals may contribute. And there was recently a study called the RESPOND study that was from about 17 European cohorts. And they reported their data in Lancet in middle of last year. And they basically looked at the cohort and tried to adjust for confounders and reported that in those who were treated with an integrase strand transfer inhibitor, that they seemed to have an increased risk of cardiovascular events during the first 6 months that remained at a higher level through about 24 months, and then sort of started to return to that of those who weren't receiving these INSTIs. Now, obviously, there are lots of limitations from these kinds of observational studies. There's always going to be prone towards bias. And it's really important for other data sets to look at this question to try to see if there's a consistent finding. So the Swiss cohort group did that. Now, it was a bit smaller cohort than what was seen in the RESPOND study, but they had about 6,000 people that were first starting antiretrovirals from about 2008 on, when integrase inhibitors first became available. So the goal was to try to look, not truly a randomized control trial, but to kind of mimic it at those who chose to start an integrase inhibitor versus those who started other antiretroviral therapies. And you can see a little under 2,000 started an INSTI, and about 3,500 started other antiretroviral therapies. And then they looked at the baseline characteristics, and they attempted as much as possible to adjust for potential confounders. Now, as far as I could tell, they didn't specifically report on the actual distribution of instis used. They more reported on what the insti use was like in the community from which this population was taken. And it was about 50% dolutegravir, and then a mix after that of boosted elvitegravir and raltegravir and a little bit of bictegravir. And these were their findings, that after adjusting for confounders, they saw no difference in about the 116 total events. There was no difference in the rate of cardiovascular events between the groups. So not consistent with what was seen in the RESPOND study. So again, clearly calling for more studies of large cohorts to further try to address this important question. Now let's switch to modifying therapy in suppressed patients. This is one of the most common things we do in clinical practice, which is why I thought it was really important to share some of the important studies that came out of CROI. The first one that hopefully many of you have already heard about was the so-called SOLAR study. This was a randomized controlled trial of adults living with HIV who were stably suppressed and interested in being in a trial that would include long-acting cabotegravir/rilpivirine. The important thing about this study that distinguishes it somewhat from the other registrational trials was that all of these individuals were on bictegravir FTC TAF at the time of enrollment. They all had to be suppressed for at least 6 months. There were almost 850 people, and they were randomly assigned to either continue bictegravir FTC TAF or to switch to cabotegravir/rilpivirine. And then they had the option of going with the oral lead-in for a month that is commonly used in clinical practice, although considered optional, at least in the United States by the FDA, or to go straight without the lead-in to long-acting cabotegravir/rilpivirine every 2 months. And the endpoint was assessed at about 12 months, depending on the group, and it was plasma viral loads greater than 50 as the primary endpoint and less than 50 as secondary, very similar to other trials of switch in suppressed patients with the non-inferiority margin of 4%. And they defined confirmed virologic failure as 2 consecutive RNAs at greater than 200. And they also looked, of course, at safety and tolerability. And anytime you're looking at long-acting therapy and the injectables, they wanted to know about patient preference and treatment satisfaction. So here are the primary results. Virologic non-response on the left. You can see the people with viral loads at greater than 50 were extremely rare. And the proportion that maintained viral loads of less than 50 was in the 90–93% range. So it clearly met the non-inferiority endpoint at 12 months. And there were 2 people who received long-acting cab/rilpivirine who met the confirmed virologic failure criterion. And this was often seen in these people, they had development of rilpivirine and INSTI resistance-associated mutations, like had been seen in the other trials, meaning that virologic failure is very, very rare, but those who fail are at some risk of acquiring resistance to the 2 classes for which they're being treated. From a safety perspective, adverse events were actually pretty similar between the groups. The big difference was treatment withdrawal due to adverse events was higher, although still less than 5% of those who switched to long-acting cab plus rilpivirine. Injection site reactions, as has been seen before, was common, but usually mild, grade 1 or 2, and short-lived. When they asked about preference, 90% of individuals preferred long-acting cab/rilpivirine, and then they looked at satisfaction. They also found that those who were switched to long-acting cab/rilpivirine were highly satisfied with the therapeutic option. So this is a study that illustrates some really important findings about the use of long-acting cab/rilpivirine, very similar to the other trials, only again, in this case, all switching from bictegravir FTC TAF. It is always important to know when we talk about preference and satisfaction that this is a select population of individuals who have chosen to participate in a long-acting trial. So they're coming in thinking this is something they're interested in, and we need to think about satisfaction and preference in that context. Now, another important question that will come up again during the course of our discussion this morning is what happens with weight. a lot of interest in the potential relationship between certain antiretrovirals and weight gain. And particularly, there's been a lot of data suggesting that second-generation integrase inhibitors may be associated with increased weight compared to alternative options. And then a suggestion that perhaps TAF, particularly compared to TDF, but TAF may also be associated with weight gain. So the nice thing here is we've got people who are going from a BIC TAF containing regimen and going to an alternative long-acting integrase without TAF. And you can see what happened to weight over the 12 months. In those individuals who remained on bictegravir FTC TAF, they had a small increase in weight from baseline, where there was a very small decrease in weight in those who switched. Again, the clinical relevance of this isn't really clear, but there is a difference. And in thinking about how this may work in the context of, shifting somebody based on BMI from being normal weight to overweight or overweight to obese, you can see in the bar graph on the right that there was a larger number of people who went from normal, BMI less than 25, to overweight, 25 to 30, in those who received bictegravir FTC TAF for an additional 12 months versus those who switched to long-acting cabrolpivirine. If you look at those who went from overweight, 25 to 30, to obese, over 30, you can see there was really no difference. And they reported that there was no clinically relevant changes in hip or waist circumference or frequency of metabolic syndrome and insulin resistance between baseline and 12 months in each of the arms. So this is another switch study in people who are suppressed, although it's a little bit different. Here, the question is, in the context of long-acting therapy, there are lots of challenges. Obviously, it's not going to be for everybody. There are these mild injection site reactions. But perhaps one of the biggest challenges is that it requires people to come into a clinical setting to get their injections every 4 or every 8 weeks, depending on how they're receiving it, because it is an intragluteal injection. There's interest in trying to figure out if there's perhaps an easier way to administer the same drug, and perhaps one that could potentially be given by self-administration. So what this study did was it tried to look at what the pharmacokinetics were of taking people in the Atlas 2M study, which was the study of either every 4 or every 8 weeks of cabotegravir rilpivirine, who were getting it all intramuscular in the gluteal area, and then transitioning them to the injections in the thigh, either at every 8 weeks or every 4 weeks. So this is the follow-up data, and this is the pharmacokinetics that were observed. And they found that you can see relatively similar curves, and that overall, for both cabotegravir on the left and rilpivirine on the right, that it maintained very similar levels over the course of the study when they switched from gluteal to thigh, and that these levels were far above that dotted line, horizontal line at the bottom, which represented the protein-adjusted inhibitory concentration 90%. So it looks like you get very good levels that are similar to what's seen intragluteal and should be sufficient to maintain virologic suppression. So the troughs with thigh injections were good. The difference between the two was probably not clinically relevant, but there was some difference from a tolerability perspective. If you asked people what was preferred, again, remember they all switched from intragluteal to thigh, only 30% preferred the thigh and 70% preferred the intergluteal region, and this was mostly driven by differences in discomfort. So here's another study that tried to address the question of how different therapies might impact weight, and importantly, in this case, how changes in therapy. So remember the ADVANCE study. This was one of the most important randomized controlled trials that informed us about the potential impact different therapies may have on weight gain. So remember, this was a study done in resource-limited settings of over 1,000 participants who were randomly assigned to receive either TDF, FTC, efavirenz along the standard of care
in resource-limited settings, or to dolutegravir-based regimens, which became standard of care. And in this case, it was either with TDF-FTC or TAF-FTC. And as you probably recall, this study demonstrated, particularly in women, but both women and men, that the greatest weight gain were in those who received, for the first time, a TAF-FTC dolutegravir, followed by a significantly lower weight gain in those who received TDF-FTC plus dolutegravir, and then even lower than that, the TDF-FTC efavirenz. And again, this was really prominent, particularly seen in women, where that dolutegravir TAF-FTC weight gain was on the order of 10 kilograms. So the CROI study was a study of 172 individuals followed in Johannesburg who were in those three arms and then were switched to TDF, 3TC, and dolutegravir. So let's assume for a moment that there's probably not much of a difference based on the data available to all of us between FTC and 3TC. So the key change here is that those who were already on dolutegravir either stayed on their regimen or switched from TAF to TDF. And then the efavirenz TDF-FTC group really had a wholesale change to the new integrase inhibitor, but stayed on their nucleosides. So it's a great opportunity to look at what happened to weight. And you can see the data in women and in men. This was at a prolonged follow-up. And you can see in the yellowish block, the switch to this new regimen of TDF 3TC dolutegravir. And let me start in the middle. So these are the people who were randomly assigned to TDF-FTC dolutegravir in advance and stayed on that regimen. And you can see their weight gain was sort of gradual increase, which we see when people start any therapy usually. And it just sort of continued to be a slow, gradual increase over the ensuing year or so on the switch. And then you've got the individuals at the bottom who started out on an efavirenz-based regimen and switched to the integrase. Again, substantial data suggesting the integrase is associated with more weight gain, particularly if you switch from efavirenz, and indeed, that is what happened. But then perhaps the most interesting group was the group at the top. These are the people who are essentially on the exact same regimen, except they switched from TAF to TDF. And they did indeed experience what looks like a relatively substantial reduction in weight. So switching somebody who's on a TAF FTC integrase-based regimen to TDF FTC integrase-based regimen did indeed result in a weight loss. Now, how much of this is an effect of taking off TAF, which may be associated with weight gain, versus switching to TDF, which some studies suggest may be associated with weight loss? It's impossible to know from this study, but at least you can see most prominent in women who have the most effect from weight as far as therapy. You can see that in the group who switched from TAF to TDF, there was indeed a reduction in weight. So this was our pretest question number one. Let me bring you back to it. You have a female patient who's gained 20 pounds over 2 years while taking dolutegravir FTC TAF. Which of the following can you tell her, based on the CROI study, may happen to her weight if she switches to dolutegravir FTC TDF? Gain weight, lose weight, no change. There's no data to inform this question or you're unsure. Go ahead and vote. Lose weight. So 85% of you, absolutely correct. Based on the characterized data set, you would tell this person that there is a chance they may lose weight. Obviously, this is across a population. Every individual is different, but that's exactly right. Great job. Now, this was another study, again, in stably suppressed individuals, but in this case, pregnant individuals. And as many of you are aware, we have pregnancy guidelines for use of antiretrovirals, and we have preferred options. We have options that are considered insufficient data. And then we have options that are not recommended. And some of the key factors in becoming a preferred option is some safety and efficacy data in pregnancy for sure. But one of the most important things is the pharmacokinetics, because we know that during the second and third trimester, you have an expansion of the volume of distribution and that you can have a reduction in levels. And you want to make sure that this reduction in levels that routinely occurs during these stages of pregnancy are not clinically relevant. So a study that was developed to address this across numerous different antiretrovirals was this IMPACT study. And what they did was they took individuals, open label, parallel group, multi-center study of pregnant women living with HIV who were on a stable regimen. And they simply followed the pharmacokinetics during the second and third trimester and then postpartum, when presumably that difference in volume of distribution goes away. So that's what was done here using bictegravir, which up until now has not been considered one of the preferred options, probably for a variety of reasons, including the absence of this kind of pharmacokinetic data. So this is stuff that the guidelines panels will be looking at very, very closely. Like most of these trials, it's a fairly small study, 10 in the second trimester, 21 in the third trimester, and then 11 with postpartum data. And importantly, there were no adverse events associated with bictegravir, that 90% were suppressed at delivery, only one with an RNA greater than 200 at any time point. So again, it maintained suppression. In all infants that were born were uninfected. So that's all obviously critically important information, but the study is primarily looking at the pharmacokinetics that are described in the figure on the right. And you can see that that top curve represents postpartum, and the levels are indeed higher than what you see during the second and third trimester. However, the levels are far above the dotted horizontal line at the bottom, which is that protein-adjusted EC95. So it appears based on this data that bictegravir was well tolerated, safe, maintained suppression, and had levels that far exceeded what would be needed to maintain suppression. So again, really important data in thinking about potential options for pregnant women. Now I'm going to switch gears and talk a little to you about islatravir. Many of you remember islatravir, a nucleoside reverse transcriptase translocation inhibitor. It's been under development for quite some time and has these properties that made it really promising for a variety of different settings. One of those properties is it's extremely potent and is active at sub-milligram doses per day. It also has a really long half-life. So what that translates in is the possibility, again, of small fixed-dose combinations, since the drug mass is so small. And with the long half-life, potentially longer long-acting therapies, including using novel delivery methods like implants, especially for things like prevention. So it was looking at it for treatment and for prevention, but on December of 2021, it was noted that those who were receiving this in the treatment trials had a reduction in their absolute lymphocyte count and in their CD4 T cell count. And that led to a hold of the product while more information was learned. And it was proposed that the mechanism might be the accumulation of the triphosphorylated form in cells, resulting in apoptosis. And in fact, what was seen in these clinical trials is that you saw this predictable reduction. It seemed to be dose related. The higher the dose given, the greater the reduction in lymphocytes. And when you stopped the drug, it appeared to be reversible. So what Kate Squires presented at this meeting was a summary of the key studies, some phase 2, some phase 3 studies for prevention. In the prevention studies, they used higher doses, 160 to 120 milligrams per month. And then in the treatment trials, there were 2 virologically suppressed and 3 virologically suppressed and a phase 2 treatment naive. And they used a variety of different doses, including one of the studies using weekly doses with a novel NNRTI, that 8507. 2 of the virally suppressed trials used 0.75 milligram dose with doravirine. So a novel combination that did not include any of the routinely used nucleosides and used this second generation NNRTI. And then the treatment naive trial again used the novel combination, but was more dose finding, 0.25, 0.75, and 2.25. And that was the study. And what she reported was the effect on lymphocytes. This is total lymphocytes, similar findings with CD4 cells. And if you look at the PrEP studies in the left-hand panel, you can see using these high dose, the 60 milligrams once a month of islatravir, there's a pretty substantial reduction. Now, what the clinical relevance of these kinds of reductions are is really open to debate, but there's clearly a bigger reduction. And then if you look at the treatment study, looking at weekly 20 milligrams of islatravir with the NNRTI, again, you saw reductions across all of the different doses, and it was substantially different than what was seen in the control group with bictegravir FTC and TAV. And then finally, if you look at the doravirine 100 milligrams, islatravir 0.7 milligrams a day studies, again, you can see a modest but decrease in lymphocyte count compared to an increase in those who received the comparator arm. So what was seen in these studies was that there was truly a dose-dependent effect. And in that phase 2 treatment trial, they really didn't see a significant reduction in the 0.25 and only a modest reduction, but a reduction in the 0.75. So the FDA has subsequently said they can move forward with the development of this drug for treatment, first-line therapy, and for those who are suppressed, but using the lower dose, the 0.25 milligram dose. And they're still on hold for consideration of potential PrEP use of islatravir. So this is a lead-in to 2 switch trials that were presented at this meeting that really were initiated before all of this happened. And these were the treatment-suppressed patients who were then going to switch to the doravirine standard dose 100 milligrams with islatravir 0.75, which based on the early phase 2 data before this whole lymphocyte issue came up, seemed like it might be the right dose. So again, in looking at the results of this in the next trial, keep in mind that it is using the 0.75 milligram dose of islatravir, which is not the one that's moving forward, the 0.25. Nevertheless, it's very informative of what is a really novel combination of 2 drugs. So this were individuals, a non-inferiority trial of stably suppressed people for at least 3 months on a 2 or 3 drug regimen without a history of treatment failure, no known resistance to doravirine, no active hepatitis B because they're not receiving a Hep B drug. And they stratified these people who were on a variety of different regimens based on their baseline antiretrovirals. And they randomly assigned them for a year to continue their baseline antiretroviral therapy or switch to doravirine islatravir, again at the 0.75 milligram dose. And here's the primary and secondary virologic outcomes. The primary one, as usual, is the proportion of people with viral loads of greater than or equal to 50 copies per mil at 48 weeks. And you can see that it was extremely rare. There were none of the individuals who switched to doravirine islatravir, and there were 5 or 1.5% in those who continued their baseline regimen, and about 94 to 95% remained at viral loads of less than 50. So clearly, again, using the 0.75, I don't think there's any reason to believe 0.25 will perform less well, but we don't have that data yet. You can see clear non-inferiority and high rates of virologic suppression with this novel combination. There were no confirmed virologic failures in the doravirine islatravir group, 3 who received their baseline antiretrovirals, 1 INSTI and 2 non-NUPs resistance were identified. As far as the CD4 T lymphocyte counts, again, baseline versus week 24 versus week 48. And you can see that at baseline, very similar CD4 counts, but as you monitored people at week 24 and particularly at 48, you can see, although the figure looks very similar, it's clearly a lower CD4 count in those who were switched to doravirine islatravir 0.75 milligrams. It went down by a mean of minus 30 as opposed to going up a mean of greater than 40 in those who continued their antiretroviral. So again, a very modest difference, the clinical relevance of which is unknown. And this is going to be something that we'll look at carefully in future trials that will be using the 0.25 instead of 0.75 milligram dose of islatravir. So here's a second study, very similar study design. The difference here is that these people weren't on a variety of different background regimens. They were all on bictegravir FTC TAF. Otherwise, the same study design, stably suppressed for at least 3 months, no underlying resistance, no hepatitis B, and they were randomly assigned to stay on their BF TAF or to switch to doravirine islatravir, again, at the 0.75 milligram dose. And here are the results. Those who switched to BF TAF versus doravirine islatravir, the numbers with a viral load of greater than or equal to 50 was extremely small, 0.6 versus 0.3%, clearly met the non-inferiority criteria with 94% or so in both arms, maintaining viral loads of less than 50. There was one person in the doravirine islatravir group with confirmed virologic failure, but no resistance, and they reported no islatravir levels at the time. As far as the CD4 change, again, using this higher dose of islatravir, it reduced by about 20 cells in the doravirine islatravir group versus going up by 40 cells in those with BF TAF. And there were similar drug-related grade 3 and 4 adverse events. So again, not relevant based on what's moving forward, but perhaps a hint of a very promising potential option for the future as we start to see the data using the 0.25 of islatravir. Now, this was really a proof of principle study, and it was modified a few times, and it's not clinically relevant right now, but I think it was really important and very informative. And it's starting to think along the lines of long-acting therapy version 2. We've got long-acting cabrolpivirine every 4 weeks or every 8 weeks that works great, but has limitations. The concept of could we go longer has come up repeatedly. And with lenacapavir, this new capsid inhibitor that can be given subcutaneously every 6 months, there's a lot of interest in saying, gee, if we can only find good partners for lenacapavir, could we potentially treat people just 2 days a year to maintain viral suppression? So that's what this study was designed to do. And the drugs they used to partner with it were 2 broadly neutralizing monoclonal antibodies, this TAB and ZAB. So the idea was to administer TAB and ZAB with lenacapavir every 6 months and see if you could maintain viral suppression. Now, during the course of the study, there were some issues. The lenacapavir was put on hold because of some storage vial compatibility, and it required that they modify the protocol a little bit, with the primary endpoint ending up to be that sort of 6-month cut point. So what they looked for were adults living with HIV, virologically suppressed for a prolonged period of time. So a pretty pristine population, at least 18 months. They had to demonstrate viral susceptibility in vitro, their virus, to TAB and ZAB. So BNABs are great, and they're broadly neutralizing, but they don't neutralize 100% of the viruses circulating in the community. So in this particular proof of principle study, they had to prove that they did. And then they had to have a CD4 nadir of greater than 350 and a CD4 at the time of study of greater than 500. And they randomly assigned them to lenacapavir with TAB and ZAB at 1 of 2 doses, with the standard oral lead-in on day 1 and 2 of lenacapavir. So this is the consort. Normally, I wouldn't take a lot of time to present a consort when we're rapidly trying to talk about sort of the highlights of studies from CROI, but I think this one's important. Perhaps the most important thing is if you look at what happened after screening, that those who met BNAB susceptibility criteria was less than half of the people screened. So again, this is an issue when we start to think about using BNABs in this way. But ultimately, they did have 21 individuals who met criteria, who were split between the low dose and the higher dose of ZAB, and they looked at rates of virologic suppression, and you can see that it was 90% of the viral loads were less than 50, of 10 in each group. There was one who had a viral load of greater than 50, and then one who had no available data, and that's how you get the 90%. So again, not readily available in clinical practice, but a proof of principle that if we compare multiple active drugs that have half-lives that would allow for every 6-month dosing, we may be able to get away with treating people as infrequently as 2 times per year. Now I'm going to switch gears from managing suppressed patients to viremic patients. This was a study that got an enormous amount of attention at the meeting, and this was the experience at San Francisco General Ward 86. So this is an underserved patient population, often very challenged. And what they wanted to do was to see if they could provide long-acting caprylipivirine as a way to assist these challenged patients with a regimen that perhaps would be more easy to stick to. So they were looking at screening people. They developed a protocol to screen people biweekly and review as to their potential eligibility and interest in caprylipivirine as an injectable. And they had within their system, they have really extensive wraparound services that allow them to do outreach. In fact, the people who enrolled in this trial had to agree that every 4 weeks, the clinic, they would come for clinic visits and they'd have a lot of active outreach by the staff. So all of this is fine and good, but the key thing that was different about this from other studies that have been presented was that viral suppression wasn't required. And as you know, the current indication for long-acting caprylipivirine is limited based on the registrational trials to those who are stably suppressed, and generally based on the trials who are highly adherent. So this was deviating to a population that perhaps was a little bit more challenged with adherence and weren't necessarily virologically suppressed. They couldn't have resistance to rilpivirine or INSTIs, and they ended up with 133 people that they reported on at the time of the meeting. And the interesting thing about that group was that 57 or 43% were actually viremic. So again, not consistent with the package insert and the current indication. And they had viral loads of over 20,000. You can see in the table on the right, it was also a very challenged population, unstable housing at 60%, homeless in almost 10%, a lot of substance abuse, and a lot of mental illness. But in the context of this one clinic, with a lot of wraparound services and experience in dealing with some of these difficult challenges our patients are confronted with, like homelessness, they were able to put people onto long-acting caprylipivirine. And they reported the results. The on-time injections occurred in about 75%, because again, these people had to come back every 4 weeks. Once they were stably suppressed for a while on every 4 weeks, they did allow some to go to every 8 weeks. And they reported that amongst the 76 people who were suppressed at entry, 100% during the course of the follow-up so far remained virologically suppressed. Now, the more interesting group was this group that they were treating almost out of desperation. These 57 people who, despite all efforts, were unable to get suppressed. And it wasn't because they had selected for a lot of resistance. Those people were excluded. It's because they simply couldn't consistently take their medications. And they reported that 55 of the 57 achieved suppression at a median of 33 days. And that they also said that you could recognize those who weren't going to make it pretty quickly. The two with virologic failure both demonstrated that in less than 24 weeks, both with minor resistance mutations that were identified. So they reported overall a virologic failure rate about 1.5%, similar to what's been seen in the registrational trials. In the subgroup of viremic patients, it was higher. It was about 3.5%. But again, small numbers, the confidence intervals are wide. And I think it's really a proof of principle that in the right clinical setting, you could potentially think about using a long-acting regimen in those who are poorly adherent, and even those who are not viremic, but without having previously selected for a lot of resistance. Again, with all the limitations I mentioned of duration of follow-up, a single clinic, and issues like that. So with that in mind, I have a quick polling question for you. If available, would you use long-acting caprylipivirine in any of the viremic patients in your clinic? Definitely yes, definitely no, probably, possibly, not sure. Oh, great, nice mix. And, definitely yes, that's interesting. About almost a third, and a third said probably, a third said possibly. Very few definitely knows, which is really interesting. I think that's very similar to what the response was in the audience, I think, during the discussion section of this presentation. Very intriguing, but clearly some concerns and limitations. So let's talk about another study in viremic patients. This is a follow-up, week 80 of the Calibrate study. So as you know, lenacapavir given every 6 months is now FDA approved for highly treatment experienced patients. This was a small phase 2 trial looking at it as a novel strategy in treatment-naive individuals. So these were all naive adults living with HIV, no active Hep C or Hep B co-infection. And it was split across 4 arms. 25 individuals received BF-TAF as the control. And then in group 3, it was oral lenacapavir with FTC-TAF with extended follow-up. And then the interesting groups were group 1 and 2. So these were all individuals who received, after their oral loading lead-in dose with lenacapavir, received every 6-month lenacapavir with FTC-TAF. So essentially a 3-drug regimen with lenacapavir as the anchor drug. And then those who were suppressed at week 16 and 22 switched to either lenacapavir with TAF or lenacapavir with bictegravir, novel 2-drug regimens. And here's the data. I'll focus your attention because of time on the right-hand side of the slide where you can see the proportion of viral loads of less than 50 across the different arms. Remember, the interesting arms were treatment group 1 and 2, purple and orange. You can see pretty high rates of virologic suppression, again, small numbers, and approaching, although not as high as what's seen in the control group with BF-TAF, but again, the numbers are small. And the individuals' viral loads are greater than 50 were, again, pretty small across the groups, with some resistance identified in treatment group 1 and 2. And this has been seen in the experience trials that while lenacapavir is an extremely potent drug with huge potential every 6-month dosing, it probably doesn't have a real high barrier to resistance. And if things don't go right, there is the possibility of resistance being selected for. Now, here's another really interesting and important study, and this is in people who are experiencing virologic failure. This was people living with HIV who were failing a first-line regimen with non-nukes and 2 nukes for a prolonged period of time. They had no previous PI or NST, and this is very similar type of study design, it turns out, to several of the other trials that have been seen in the past. First, looking at failure, NNRTI and nuke failures. We had seen some early data with boosted PI and nukes and boosted PI with integrase inhibitors showing good virologic efficacy. And then they added a 3rd arm in this so-called stage 2 based on new data becoming available, I assume presumably from the Nadia and to a lesser extent the Dawning trial, where they said, well, what about dolutegravir with nukes? So you may remember the Nadia trial took people who were highly treatment experienced with non-nukes and nukes, had lots of resistance to both classes, and randomly assigned them to darunavir, ritonavir with nukes versus dolutegravir with nukes. And it showed similar virologic efficacy, even in people with a lot of underlying nuke resistance. Even with resistance to tenofovir and FTC, they found that dolutegravir worked. And in fact, they had an arm in that study that used AZT3TC instead. And at 96 weeks, they actually found the tenofovir arm worked better in these people, even though half had K65R than the AZT arm. So this is another study that's looking at a similar population. And here are the virologic results. So you can see the difference between darunavir, ritonavir, and nukes versus dolutegravir in the boosted PI clearly favors the dolutegravir boosted PI regimen. Now, how much of this is related to efficacy? How much of this is related to the fact that most of the nuke use in this setting was zidovudine 3TC, which is clearly not going to be as well tolerated and could drive some higher rates of virologic failure or less viral suppression. And then stage 2, again, similar results for those 2 arms, but now we bring in the dolutegravir with 3TC or FTC and TDF. And you can see, again, 80% suppression rate. So similar to what was seen in Nadia, it looks like dolutegravir with recycled nukes, even where you expect there's probably underlying resistance, seems to be very active. So what you come away from this is that, again, reassuring that these 2nd-generation integrase inhibitors are likely to be effective even with nukes in the setting of resistance, and have obviously advantages over boosted PIs, convenience, tolerability, drug-drug interactions, if you can use them instead. So this is reassuring. What we didn't get shown at this study, for this study, was what the actual resistance patterns were. I assume we'll be seeing that soon at a meeting in the future where we'll see the specific resistance data. Now, this was the Vicenne study. This was another switch study that, again, was addressing a similar issue in resource-limited settings. And it's saying, what about using drugs like TDF or TAF with 3-TC dolutegravir in people who've experienced first-line failures with nukes and non-nukes? The regimen for which there was additional data presented at this meeting is outlined here at the bottom, the virologic failure group. So again, very similar to Nadia in a sense, and somewhat similar to that D2F study, and that they were looking at whether you could use tenofovir, whether it's TAF or TDF, with 3-TC and dolutegravir to get suppression in a group of people who had a lot of resistance, and compared it to boosted PIs, admittedly not contemporary boosted PIs, lopinavir, ritonavir, and atazanavir, ritonavir, and again, not really contemporary nukes, but nukes that were commonly used in resource-limited settings in people experiencing virologic failure. So what did they show? Well, they showed, not surprising, the resistance data that all of these people, virtually 92%, had nuke mutations. And interestingly, 2/3 had K65R mutation. So the Nadia trial, it was over 50%. Here, it's over 60%. And despite that, those who received dolutegravir with a tenofovir-based regimen had very high rates of virologic suppression, about 96%. And those who, they saw similar results, regardless of resistance pattern, and even if you had K65R. So I think in summary, if you look at these D2F, the Nadia study, and now Vicenne, we now have 3 large studies, 2 of which with extensive resistance data, showing that dolutegravir and its advantages over an INSTI's advantages over a boosted PI with nukes, even recycled nukes, for which there's not full activity, have very high rates of virologic suppression. And in this case, this is with tenofovir, which we don't expect to be terribly active with K65R, are working very well. And obviously, tenofovir-based regimens have distinct advantage over AZT-based regimens from a tolerability perspective. So these studies together really support what's been incorporated into the guidelines in the setting of virologic failure, really the use of a boosted PI, but also the use of perhaps a better tolerated and easier to take in second-generation integrase can be given with nukes, even in the setting of a lot of nuke resistance. And then many have speculated that perhaps we can use this data in treatment failure to extrapolate a little bit to those who are stably suppressed with underlying nuke resistance. So our post-test question number 2. A patient experiences virologic failure 2 years ago on TDF-FTC efavirenz with K65R, 184V, and 103N, then is lost to follow-up, and now presents anxious to restart therapy with the CD4 of 45 and an RNA of 245,000. The other labs are within normal limits, and the question is, which of the following would be the best option? So you can use darunavir cobicistat TDF-FTC, darunavir cobicistat zidovudine 3-TC, dolutegravir TAF-FTC, or dolutegravir zidovudine 3-TC, or none of the above. Go ahead and vote. Dolutegravir TAF-FTC, almost 80%. And I think that's right. You know, the reality is all of these are likely to work based on the data that's available to us. But I think if we think about the distinct advantages of a non-boosted integrase inhibitor over a boosted PI, it has advantages and perhaps would be considered more favorable. And certainly tenofovir or zidovudine in somebody where you're not worried about things like bone and renal toxicity has distinct advantages with regards to tolerability. So I think while all of these options will likely work, C is probably the best answer. And I agree with the 78% of you.
Now, the last study I'm going to talk about is the Capella study. This was the registrational trial that led to lenacapavir being approved in the United States in highly treatment experienced patients. So again, treatment experienced people on a failing regimen, resistance to greater than or equal to 2 agents from 3 of 4 main antiretroviral classes: reverse transcriptase, protease, integrase, non-nukes, and then had less than or equal to 2 fully active agents available. And that was the randomized double-blind cohort. Then there was a non-randomized cohort for the select group who came in, and then between pre-randomization and baseline, they had a decline in their viral load, suggesting perhaps some adherence issues or a viral load of less than 400. So we'll focus our attention on the relatively small number of people who were enrolled in the randomized portion, and they received oral lenacapavir or not, added to their failing regimen. So in essence, functional monotherapy, like many of these trials in this population, in looking to see if there's intrinsic activity at day 14, after which they would receive optimized background regimen to minimize the risk of developing resistance. And again, a highly resistant, 99% nuke, 97% non-nuke, 80% PI resistance, 70% with INSTI mutations. And this was the extended follow-up of this small phase 3 trial. So the HIV RNA suppression at less than 50 copies, you can see it was about 78%. Again, with very low levels of virologic failure, considering the patient population. And they saw pretty good viral suppression, even in those who had no or 1 predicted active drug in the optimized background regimen. CD4s went up. Lenacapavir resistance did occur. Again, a highly risky population. You really do need to make sure, since the barrier to resistance isn't real high with this drug, that you've done the best you can to add something to the optimized background that will contribute to viral suppression. They noted 9 who had capsid resistance. 4 of the 9 resuppressed during receipt of lenacapavir. And in general, well tolerated. There were some injection site reactions in the sub-Q injections that are given every 6 months. No serious drug-related adverse events were noticed. And with that, I will stop. Thank you all very much for your attention, and turn it over to Judy for the question and answer session.
Thank you so much, Eric. That was really great. A comprehensive review of a lot of new information. And we have a few questions that I will ask, and I have a couple of my own comments or questions. But the first question is from Matt Messerschmidt, and it asks, did any of the 2DEFT or the VSEND or Nadia trial actually show non-inferiority within some margin, or were they just considered similar efficacy when comparing the dolutegravir with recycled nukes versus dolutegravir and the boosted PI?
Yeah, they were non-inferiority trials, and they did meet criteria for non-inferiority. And then they actually showed in Nadia superiority for the secondary endpoint at 96 weeks compared to that nuke option, favoring tenofovir over cytovinin 3-TC. So these were fully powered studies to address this specific question.
Great. Another question from Christina Gruta about Nadia and VSEND: was the adherence factored in and the relative success of the dolutegravir arms over the boosted PI arms? If we assume equal adherence to both arms, are we concluding that dolutegravir, tenofovir, and XTC is as forgiving as boosted darunavir, tenofovir, and XTC to imperfect adherence in a population with resistance to NRTIs and NNRTIs?
Great question. And there's so much to be said about these studies. And you guys are bringing up, I think, what are some of the most important, in some ways you could say unanswered questions, but this is always an issue, right? Is how do we deal with differences in adherence? And it's really difficult to quantitate that in a meaningful way. I mean, they do things like pill counting, but when it's all said and done, it's really hard to know. And I guess what I would say from these trials that's reassuring is that the rates of virologic suppression were so high. Now, I didn't present the Nadia data, that wasn't presented here, but there was 90% virologic suppression in both groups. So if we saw a big difference between the two, you might argue, well, this may be just driven by adherence differences, but we didn't. So I think we can say with confidence that across the population of people enrolled in the trial, these were very effective regimens, regardless of baseline resistance. And I think that's particularly reassuring when thinking about how to incorporate these into clinical practice. But adherence is always going to be a critical measure and one that's difficult to account for in these trials.
Yeah, and there's an interesting sort of paradox about adherence. Sometimes people with more resistance, it's a marker that they've actually taken the drug. And so sometimes resistance actually correlates with better outcomes and not worse outcomes, because people are able to actually take the medications versus not taking them at all. So it's interesting studies looking at that.
And we see that in trial after trial. But the one thing I will add, though, along the lines of the question with Nadia, that's important, is when they looked for those who experienced virologic failure, even though the numbers were small, they did see resistance to dolutegravir in a small group of people in the dolutegravir arm that was not seen in the boosted PI arm. So I don't think we can say they're equivalent with regards to the barrier to resistance, but what we can say, I think now, based on several large studies, that the second generation integrase can be highly effective, maybe reinforcing just the point the questioner was making, that we do need to continue to emphasize adherence when we think about these kinds of regimens.
Yeah, another question about the optimized background regimen in the Capella study. Do you know if it was allowed to include fostemsavir?
I would think it was, based on the timing in which it enrolled, but I don't know if you know, Judy, I'm not 100% sure.
Yeah, I think I saw something about that, but I'm not 100% sure either. So, okay, I also wanted to just raise this question about the weight loss, which is on everybody's mind. I think that you showed the characterized study and the subgroup of women who switched from TAF to TDF, there was some weight loss, but it's a very small study. It's only 41 people. And I think that the expectation that people are going to lose significant weight, I think that weight loss may vary by where you start. And I'm not really sure that any of these intervention studies have shown that someone who's obese loses enough weight that they're not obese anymore. And we're so focused on what we can do with our ARV to potentially manage, but for obesity, I don't think changing ARV is the management strategy that we need to be focused on, because the changes are, while statistically significant, they're not really necessarily clinically significant, particularly for people living with obesity. But and there's no really good data with doravirine. And what's your thought about that? About the doravirine switch studies, there wasn't much presented about what the impact of that was on weight.
Yeah, I mean, going back to your comment, the one I made during the presentation, I think you're absolutely right. We need to be very careful in how we interpret these studies. I mean, they're all really just looking for signals. None of them are definitive. And I think it's also, I still struggle with how much of what we're seeing in these kinds of studies is an effect of tenofovir disoproxil to reduce weight versus taking away the effect of tenofovir alafenamide to increase weight. I still don't think we know the answer to that question. I think the doravirine studies are really interesting because the hope was, based on some of the early data with doravirine, that we weren't seeing the kind of weight gains that we saw with INSTIs. And here we had a large phase 3 trial of individuals who are on bictegravir FTC TAF, which we would think would be associated with some of the greatest weight gain that we've seen with these different regimens, and then switched to doravirine TDF for ETC. They didn't present the weight data, although on clinicaltrials.gov, they do have results, and it includes some weight data. I haven't seen it formally presented at a meeting that suggests there wasn't much of an effect seen. So hopefully we'll be seeing that at a meeting, a full presentation of the effect of weight from that and perhaps other related trials.
Yeah, that's a really great point. And I think, as we kind of think back about CROI and what we learned and where things are going, and you highlighted the sort of provocative results of the CAB rilpivirine in people who are adherence challenged and some who weren't viremic, whether I'm not sure that's ready for prime time. I think it's ready for more study. I think a bigger issue is, and your question was very clear, if it was available, the availability of long-acting, not necessarily to write a prescription, but to deliver in our clinic settings is really much more of a challenge than I think any of us thought it would be. And hopefully we'll see more examples about how people can successfully roll this out with appropriate support. I don't know if you want to mention or say anything about your success with that in a publicly funded clinic, but it's very challenging, I think, in a lot of settings.
Yeah, no, I agree. It's been challenging and highly motivated people. More typical of what the patients enrolled in the randomized registrational type trials. So we have not, embarked upon treating these particularly high-risk individuals or those who are viremic. Although I must say we are frequently tempted because our patients, we're desperate to be able to do something. But I do think we always need to hold our breath a little bit, stop or take a breath, I should say, before we do things out of desperation, make sure we think it through carefully. And the Ward 86 experience, clearly as described by Monica Gandhi, was very carefully thought through. They didn't just go out on a whim, you know what, maybe this will help you, good luck.
Yeah, and absolutely. And I think some also motivated by people who really had no other option. I think that's a key point of people who can't take oral medications for various reasons and just have not ever been able to be suppressed. I think that's like compassionate use of the drug. And I think that's something, it's really maybe where the focus should be initially is on those who have no other options, then exploring the best ways to study this and get definitive data. But if there are no other options, you really are propelled to try to do something. And I think doing it in a carefully controlled setting where you collect data on it is really an important contribution. So that study is really valuable in that regard.
And hopefully it will stimulate larger studies across multiple different centers to see, how generalizable it really is, because it would be really important. Absolutely.
Yeah, no, I think that's the hope for long-acting therapy, that it will really help people who've been challenged with oral meds. Okay, I am not seeing any other questions. I have a few things to wrap up. Let me look one more time. There's a question. Okay, this is a question from a participant about whether you recommend, or where do we stand today on treatment interruptions and people who are suppressed on treatment for a long time. The questionnaire is asking, after 30 years, is this something that you would endorse for trying to determine if they still require ART?
Yeah, it's obviously every patient is different, but right now, based on the data that's available to us over the years, there's really little reason to believe that we could predict who's not going to experience viral rebound, and they're likely to be an extremely rare subset of people. And I think we have overwhelming data that even people who may marginally control their virus to some modest level, that there's probably ongoing harm from chronic inflammation and other factors. And I balance that against the simplicity and tolerability for the majority of people with standard available treatment, that I really wouldn't advise that we consider that as an option for patients. And those who are thinking about doing it, we just have a real careful discussion with them about what kind of data does exist and what the potential risks are. And I think the risks are substantial.
Thank you so much. And thank you, Eric, for that really fantastic review. As a reminder, the talk is going to be archived on the IAS-USA website and can be viewed afterwards. It is important to complete the evaluations and also your CME credit. These certificates will be emailed by 5 p.m. tomorrow. We want to hear from you about other topics that you want to hear about. And this is also a reminder for the IAS-USA annual update in Chicago on May 5th. You can register on the website. The topics really capture a lot of the really hot topics in HIV care today. It's very comprehensive. And there's also an update on May 2nd from CROI on HIV and STI prevention. So be sure to tune in to learn what was new at CROI. And then on June 22nd, we're going to have a half-day virtual course on long COVID, including how long COVID may impact people living with HIV. We have perspectives from people living with long COVID, as well as those designing studies. And then finally, the topics in antiviral medicine, the CROI issue, the long-awaited CROI issue is out. And this has a great summary by a lot of people who worked very hard to distill what was new in CROI. So I encourage you to take a look at that on the website. Another dialogue that's coming on COVID and other urgent virus outbreaks continue to be scheduled. So we also interested in hearing about other topics. We think this format of the webinar is really conducive to a lot of people's schedules. And so we hope to utilize this in the future. I really want to thank you all, and Eric especially, for being here today, but everybody for joining and participating in this, and to the IAS-USA for putting on this program today. So thank you very much.